The module Geriatric Anesthesia has been covered under 2 lectures. The lecture 1, that is this lecture, includes system-wise anatomical and physiological changes with age and its anesthetic implications. It also includes various age-related pharmacological changes. Let's begin with demography. The elderly population, which is defined as greater than 65 years old, has been tremendously increasing in various parts of the world. According to the US Census Bureau, this segment of population continues to grow from 6.1% in 1935 to 13% in 2010, and it is expected to grow up to 20% of the US population by 2040. Perhaps a better presentation of this increase in the elderly population can be seen in the age group greater than 85 years of age, which in 2010 accounted for 1.8% of the US population. However, it is expected to grow further to 4.5% by the year 2040. If we see statistics of India, according to Population Census 2011 and United Nations Population Fund, 104 million people were more than 60 years, and it is expected by 2026 it will increase to 173 million. Hence, as the percentage of this segment of population continues to grow, there is obviously an increased number of elderly undergoing surgery and requiring anesthesia. Before we proceed, we should be clear with what is chronological and physiological age. Chronological age is the actual age or the calendar age, and it reflects the number of years of life. Whereas physiological age is the actual accumulation of physiopathological changes in biologic process involved in aging. That is, it reflects the general health of the population. Interestingly, in geriatric population, there is a spectrum of elderly patients ranging from excellent health status to extremely unhealthy with multiple comorbidities. For example, an 80-year-old patient might have less comorbid condition than 70-year-old. So for anesthesiologists, it is the physiological age which decides anesthetic management. These are the various systems covered in this lecture. Let's begin with anatomical and physiological changes in respiratory system. Starting from the chest wall, there is increased rigidity of chest wall because of calcification of intercostal cartilage. Arthritic changes are also seen in costovertebral joints. This increase in calcification of rib cage results in decreased compliance of the chest wall. The osteoporotic vertebral collapse results in kyphosis of the thoracic spine. This increases AP diameter of the chest at the expense of the lateral diameter, leading to barrel chest deformity. The strength of respiratory muscles like diaphragm and intercostal muscles decreases with age. The weakening and flattening of diaphragm and loss of mass of the intercostal muscles increases work of breathing in older population. Hence, they are prone to respiratory failure. The elasticity of lung tissue decreases due to reorganization of elastin. Moreover, the surfactant production also decreases. This loss of elastic recoil of lung tissue increases lung compliance, causes collapse of small airways, and overdistension of alveoli. Here we can see that decreased radial traction by the elastic recoil of the surrounding tissue and loss of cartilaginous support with age results in collapse of small terminal conducting airways. However, the size of central airways increases with age because of loss of cartilaginous support. This increases the anatomical dead space. As we discussed, aging results in decreased elasticity of lung tissue and surfactant production. These changes result in overdistension of alveoli, which are not adequately perfused. Thus, physiological dead space increases or functional alveolar surface area decreases. The effect of these changes are decreased gas exchange and increased ventilation perfusion mismatch. The anatomy of upper airway also changes with age, like loose teeth, loss of dentition or buccal pad of fat. This results in sinking of cheeks, making it difficult to create a good face mask seal. So difficult ventilation is anticipated in these patients. There is loss of pharyngeal muscle support. The reason why elderly patients are very prone to airway obstruction, especially during induction or after extubation. Coming to physiological changes. Age-related changes in static lung volumes can be better explained by this graph. Here we can see total lung capacity corrected for age remains unchanged throughout life. There is slight decrease in tidal volume with age, whereas functional residual capacity increases 5 to 10% per decade. Residual volume increases gradually after 40, and as residual volume increases, vital capacity decreases. Closing volume and closing capacity also increases with age and exceeds FRC by age 66 in the upright position and exceeds tidal volume at some later age, which results in atelectasis, pulmonary shunting, and hypoxemia. Dynamic lung volumes like FEV1 decreases 30 ml per year with age due to decrease in maximum expiratory flows. Ratio of FEV to FEV1 also decreases by 55 to 65% in geriatric patients. The cross-sectional surface area of pulmonary vascular bed decreases with age, which increase pulmonary vascular resistance and pulmonary arterial pressure. The pulmonary vasoconstriction response to hypoxia decreased with age. The alveolar to arterial oxygen partial pressure gradient progressively increases with age up to 20 to 30 mm of Hg. The factors responsible for this increase in gradient are, firstly, because of increase in alveolar dead space, which we have already discussed that the increased surface area of alveoli is not adequately perfused, which results in ventilation perfusion mismatch, thereby increasing alveolar arterial gradient. Secondly, the diffusion capacity of pulmonary vessels decreases with age, which is also responsible for increase in gradient. And lastly, increased pulmonary shunting due to increase in closing capacity contribute to increase AA gradient. This increase in gradient is responsible for decrease in arterial oxygen tension with age. Central responses to hypercapnia and hypoxia are blunted in older adults. This increases the risk of respiratory depression after long-acting anesthetic drugs like morphine. The hypopharyngeal and genioglottal muscle tone decreases with age, so these patients are prone to upper airway obstruction, especially during sleep or induction. Protective reflexes like cough and swallowing are diminished in elderly, and mucociliary transport of respiratory epithelium also decreases with age. This increases the risk of aspiration and post-operative pneumonia. The most common pathologies seen in older population are restrictive and obstructive lung disease and sleep-related disorders. The most common sleep-related respiratory derangement in older adults is sleep apnea, which may affect 50 to 75% of patients over age 65. The anesthetic implications associated with changes are we should prefer regional anesthesia over general anesthesia to avoid risk of pulmonary aspiration, also to avoid risk of respiratory depression by anesthetic drugs. However, if GA is unavoidable, then we should pre-oxygenate these patients for 3 minutes before inducing general anesthesia. Avoid long-acting anesthetic drugs as these patients are prone to post-operative respiratory depression. One should encourage early mobilization, ambulation, chest physiotherapy, and incentive spirometry in post-operative period to minimize atelectasis. Next is cardiovascular system. Vascular changes include both increased arterial and venous stiffening with age. The arterial stiffening is due to increased fibrosis of the tunica media. This increased arterial stiffening decreases distensibility of large central arteries, which is a hallmark of vascular aging. It is responsible for increased systolic blood pressure and mean arterial pressure. Pulse pressure, which is an index of arterial stiffness and pulsatile load on arterial tree, also increases with aging. The increase in mean arterial pressure and decreased distensibility of central arteries is responsible for increased afterload. Hence, the aging ventricles has to work harder against this increased afterload. This increases stress to the ventricle muscles, result in left ventricular hypertrophy. Moreover, this increased afterload decreases cardiac output in geriatric patients. The number of cardiomyocyte cells decreases with age. However, their size increases and this increases thickness of myocardium. As a result, elasticity of the myocardium decreases, which results in prolonged contraction and slowed relaxation. What happens because of this prolonged contraction? Early diastolic filling decreases. So, in order to maintain cardiac output, geriatric patients are increasingly dependent on preload and atrial kick. Systolic function typically remains well preserved throughout life. It is this early dystolic function which is commonly seen in these patients. Cardiac valves in aging patients are usually thickened and calcified. Stenosis of aortic valve is commonly seen in these patients and it is present in 12.4% of those aged 75 years or above. Changes with aging are also evident in conduction system. The decrease in sinoatrial node cells and fibrosis of the conduction system makes these patients prone to dysrhythmias. There are increased incidence of ectopic beats. Atrial fibrillation is the most common arrhythmia seen in this age group, affecting almost 1 in 10 above 80. Atrial fibrillation eliminates atrial kick, which we just discussed decreases left ventricular filling and hence results in decreased cardiac output. Moreover, nodal cells degeneration and decreased beta receptor sensitivity with age results in lower resting heart rate as well as lower maximal heart rate achieved with exercise. Blunted baroreceptor reflex diminish normal response to postural changes and can result in orthostatic hypotension and syncope. The various CVS pathologies associated with aging are atherosclerosis of vascular system. There is increased incidence of DVT in elderly. Chronic hypertension can further exacerbate cardiac hypertrophy. Coronary artery disease, congestive heart failure, cardiac arrhythmias, or aortic stenosis. The following points should be taken care of when patient is under anesthesia. One should avoid hypotension because small decrease in circulating blood volume can lead to inadequate cardiac filling, which can significantly decrease cardiac output and impairs adequate coronary perfusion. We should avoid hypertension to reduce MI by avoiding excessive afterload and resultant increase in myocardial oxygen consumption. Avoid prolonged fasting and encourage drinking clear liquids up to 2 hours before surgery. Because of one should be careful during induction of general anesthesia as diminished cardiac reserve may be manifested as exaggerated drops in blood pressure. Because of prolonged circulation time, the onset of intravenous drugs delayed. However, induction of inhalational agents is faster. These patients have less ability to respond to hypovolemia, hypotension, or hypoxia with an increase in heart rate because of blunted beta receptor sensitivity. Coming to genitourinary system. Renal cortical mass decreases by 20 to 25% with age, mainly as a result of cortical atrophy from glomerulosclerosis. Moreover, glomerular number also decreases and loss of up to half of the glomeruli occurs by age 80, again due to glomerulosclerosis. The glomerular filtration rate decreases by about 1 ml per minute per meter square per year after age 40. And this is due to decrease in renal blood flow, which decreases by 10% per decade. This decrease in GFR results in decreased creatinine clearance. However, serum creatinine levels remains normal in geriatrics. This is because the decreased creatinine clearance is counterbalanced by decrease in lean mass with age. So, in elderly, normal or small increase in serum creatinine may represent decrease in GFR. The blunted responses to aldosterone, vasopressin, and renin, plus declined sensation of thirst with age, decreased GFR and tubular function, result in electrolyte derangements and impaired fluid homeostasis. The most common electrolyte derangement present in older adults is dysnatremias, because the aged kidney does not eliminate or retain sodium effectively. Hyponatremia affects 5.3% of hospitalized geriatric patients, whereas the incidence of hyponatremia is 1% of hospitalized patients. Hyperkalemia also seen in some patients because of impaired potassium excretion. The aged kidney also does not retain or eliminate free water as rapidly as young kidney when challenged by water deprivation or free water excess. This impaired concentrating and diluting capacity predisposes elderly patients to both dehydration and fluid overload. The common pathologies are increased incidence of UTI, especially in women, in which incidence of pelvic prolapse increases with age along with increase in UTI. Chronic diseases frequently found in the older population like hypertension, diabetes, atherosclerosis can exacerbate this normal age-related decline in renal function. Prostate hypertrophy is commonly seen in elderly male. As far as anesthetic implications are concerned, dose adjustments needed for those drugs excreted through kidney, especially in case of reduced GFR. Elderly are prone to hypotension and acute kidney injury or acute renal failure in the setting of hypovolemia or when exposed to nephrotoxic drugs. Next is gastrointestinal system. After age 50, the liver decreases from 2.5% of total body mass to 1.5% in part due to fewer hepatocytes and decreased blood flow. Approximately 20 to 40% decrease in liver blood flow occurs in older patients. Despite having fewer hepatocytes, healthy older adults typically have normal synthetic function, though they have reduced reserve under stress. Moreover, phase 2 drug metabolism does not affected by age. However, phase 1 drug metabolism, that is oxidation, reduction or hydrolysis, decreases with age because of decreased blood flow. Bile secretion also decreases with age. Hence, high extraction drugs like ketamine, morphine, fentanyl, sufentanil, lidocaine, flumazenil, whose clearance depends directly on hepatic blood flow, decreases in older age. Coming to musculoskeletal system. Aging affects the skin and muscles as well. As skin ages, it atrophies and veins often become frail. The lean muscle mass declines by about 1% per year, whereas muscle strength declines 3% annually. It means muscle function and quality decreases faster with age than muscle quantity does. Moreover, as compared to younger counterparts, older adults lose muscle mass much faster. For example, healthy older adults who were placed on bed rest for 10 days experience greater loss of muscle mass than healthy younger adults who were placed on bed rest for 28 days. Contrary to muscle mass, body fat increases with age, especially in females. Skeletal changes include increased stiffness of joints. Osteoarthritis affects about half of those aged 75 and older and can lead to limited joint mobility. Height loss due to osteoporosis of cervical vertebra or kyphosis may occur. Its anesthetic implications are, as the skin of elderly patients are very fragile, they are susceptible to trauma from removal of adhesive tape, electrocautery beds, and ECG electrodes. Proper padding should be done to avoid pressure ulcers because of fragile skin and decrease subcutaneous tissue. Fragile veins are difficult to cannulate and easily ruptured by intravenous infusions. Utmost care should be given while positioning the patient to avoid exacerbating pre-existing joint issues. Osteoarthritic changes in temporomandibular and head and neck joint may limit mouth opening and range of motion of neck, potentially making intubation difficult. Declining muscle strength is associated with increased mortality risk. Coming to age-related changes in central nervous system. Brain volume decreases with age due to decrease in dendrites and synapses. However, number of neurons in the brain does not decrease in normal aging. An 80-year-old brain has typically lost 10% of its weight. Cortical gray matter thins at a rate of 0.5 to 1% per year in the geriatric brain. Cerebral blood flow and cerebral oxygen consumption also decreases in proportion to the decrease in brain mass. The cerebral autoregulation is well maintained in geriatric patients without prior neurological disease. But there is a continual loss of neurotransmitters like depletions of dopamine, norepinephrine, tyrosine, and serotonin. The aging brain has following age-related concerns. Memory loss increases with age. In older adults, response time increases. Even learning is more difficult with growing age. However, vocabulary, wisdom, and past knowledge are better preserved. Sleep derangements are commonly seen in elderly patients. There is increased latency to sleep onset and increased awakening and period of wakefulness during the night. The increased incidence of movement disorder like Parkinson's disease are due to decreased dopamine synthesis. Mood disorders, particularly depression, affects 14.4% of geriatric patients in hospital setting. Age-related cognitive decline causes impairment of cognitive processing speed, circadian rhythm, language comprehension, abstract thinking, and social integration. Changes in peripheral nervous system include generalized increase in the threshold for nearly all sensory modalities like touch, temperature sensation, vision, hearing, sense of joint position, smell, and peripheral pain. The age-related changes observed in neuraxial system are decrease in volume and gravity of cerebrospinal fluid, increased permeability of the dura mater. The diameter and number of myelinated fibers in the dorsal and ventral nerve roots decreases, and also the area of the epidural space decreases with age. These all factors are responsible for increased block height after spinal and epidural anesthesia. The CNS pathologies are atherosclerosis, which may result in stroke, Parkinson's, or Alzheimer's disease. Anesthetic implications include there is increased risk of post-operative cognitive dysfunction, especially in patients with history of dementia and cognitive decline. Mood disorders like depression predisposes them to increased risk of post-operative cognitive dysfunction, delirium, major adverse cardiac events, increased post-operative analgesic use, and suboptimal post-operative outcomes. Geriatric patients are prone to hypothermia because of age-related dysregulation of cutaneous microcirculation, diminished subcutaneous fat thickness, impaired vasoconstriction and shivering, and decreased basal metabolism with age. However, basal core temperature of the elderly is about 0.4 degrees Celsius lower than that of the adults. Age-related dysregulation of the cutaneous microcirculation also contributes to impaired wound healing. Now, if will discuss age-related changes of neuromuscular junction. There is increase in the distance between the junctional axon and the motor end plate. At junctional axon, there is decrease in the amount of acetylcholine in each vesicle, and as well as decreased release of acetylcholine in response to a neural impulse. Whereas at motor end plate, there are flattening of folds and decreased concentration of acetylcholine receptors. Because of these physiological changes at neuromuscular junction, prolonged duration of action of both neuromuscular blocking drugs and anticholinesterases are expected. The risk of post-operative residual block in elderly patients who have received neostigmine is significantly higher than in a younger cohort receiving similar doses of this drug. Hence, intraoperative neuromuscular monitoring is strongly recommended. Some important points regarding changes in endocrine system. Pancreatic function declines with age. There is decreased insulin secretion in response to a glucose load. Moreover, insulin resistance increases, particularly in skeletal muscle. Aging also results in decrease in testosterone, estrogen, and growth hormone production. Now coming to next part of the lecture, that is age-related pharmacological changes. Before going to age-related effects on individual drugs, we would like to discuss what are the factors affecting pharmacodynamics and pharmacokinetics of anesthetic drugs in geriatric patients. These factors are: first, change in body composition, that is, decrease in lean body mass and total body water, and increase in body fat. Secondly, decreased brain sensitivity to various anesthetic drugs. Other factors are decrease in plasma albumin levels and small increase in alpha-1 acid glycoprotein, decrease in cardiac output, and reduced renal and hepatic clearance. Now we will discuss one by one how these factors affect drug absorption, distribution, and metabolism. So, decrease in lean body mass and increase in body fat increases volume of distribution of fat-soluble drugs and inhalational agents. This causes prolonged duration of action of these drugs due to a greater residual plasma concentration. Whereas decrease in total body water decreases volume of distribution for water-soluble drugs. Hence, high plasma concentration occurs of these drugs, especially after bolus doses. Though there is decrease in plasma albumin levels and small increase in alpha-1 acid glycoprotein, however, the effect of these changes on drug protein binding and drug delivery appear to be minimal. Prolonged duration of action of drugs is expected, those metabolized by liver and kidney. Decrease in cardiac output increases circulation time, which slows biophase equilibration with plasma, and hence duration of onset of these drugs increases in elderly patients. So keeping all these factors in mind, various age-related pharmacological changes of anesthetic drugs are: in case of inducing agents, modest reduction in dose is recommended because of increased sensitivity to brain. The elderly patients are more prone to hypotension and apnea because of high plasma concentration achieved on bolus dose of these drugs. Moreover, prolonged recovery is seen in these patients after infusion because of reduced clearance. Bolus dose of propofol is decreased by 20% and that of infusion dose by 30 to 50% because of increased sensitivity and decreased clearance. Even the bolus dose of thiopentone decreases by 20% as there is decreased initial volume of distribution. Moreover, the bolus dose of etomidate is decreased by 20 to 50% in elderly patients because of decreased initial volume of distribution and decreased clearance. Reduced bolus dose as well as infusion dose is recommended for benzodiazepines because of increased sensitivity of the brain and reduced drug clearance. Midazolam is the preferred benzodiazepine in this age group because of high clearance rate. The aging brain is very sensitive to opioids, especially respiratory depressant effect of long-acting opioids like morphine when given intravenously or neurexally. Hence, shorter-acting newer opioids like fentanyl, sufentanil, afentanil, and remifentanil are preferred. L-fentanyl. Because of this increased sensitivity, reduction of doses to about 50% are recommended in these patients. In case of muscle relaxants, non-depolarizing muscle relaxants are as potent in older as in younger adult. However, onset of neuromuscular block can be delayed because of decrease in cardiac output and increase in circulation time. For example, onset of rocuronium prolonged to 3.7 minutes from 3.1 minutes, whereas onset of cisatracurium is delayed by approximately 1 minute. Except atracurium and cisatracurium, rest muscle relaxants have prolonged duration of action, hence maintenance doses are needed to decrease in these patients. For example, pancronium has delayed recovery because of decreased plasma clearance secondary to delayed urinary excretion. Vecronium dose requirements decrease by approximately 36% in older patients. So these patients are at risk of post-operative residual block. The MAC, that is minimum alveolar concentration, and MAC awake for inhalational agents is reduced by 6% per decade of age over 30 years. However, because of decreased cardiac output in older patients, inhalational induction is faster, but recovery is prolonged due to increased volume of distribution in body fat and decreased pulmonary gas exchange. And lastly, because of decreased beta receptor sensitivity, elderly patients have reduced sensitivity to adrenergic drugs like adrenaline and dobutamine. These are the various references. Thank you.